Good afternoon, everyone. Today we will be introducing you chronic obstructive pulmonary disease. In short, it is COPD. I'm Meredith. I'll be doing case scenario and the complication part of this disease.
And my name is Rachel. I'll be talking about the pathophysiology of the emphysema.
My name is Walaa. I will talk about nursing management for that patient. Thank you.
COPD originally it includes emphysema, asthma, and chronic bronchitis. However, asthma is separated as another disease, and only emphysema and chronic bronchitis are under COPD. And we will be introducing you emphysema today. There is some statistic about COPD. It is the fourth common cause of death in men and the sixth common cause of death in women. COPD is the second leading cause to hospital admission. That's why we can see many patients having COPD in hospital, and we are taking care about them. 7.5% of people aged over 40 has developed COPD, and smokers are 6 times more likely to have COPD. Here is our case scenario. David Smith is a 60 years old male. He was admitted to hospital 2 weeks before. He has got major complaint of fatigue, breathlessness, stress, and productive cough. He was diagnosed of severe emphysema and hypertension. We have asked David some questions about his past history, family history, current medication, lifestyle, and the sleep rest pattern. He has got emphysema 5 years before. Otherwise, he is a healthy person. He has got no family history, however, his father is a heavy smoker and we think that it influences his smoking habit. He is now on medication of salbutamol and inhaled steroid. He has got weight change of 5 kilograms in the past 3 months, and we are going to concern about that because it's an overwhelming weight change. He doesn't have a good healthy lifestyle, that he smokes up to 30 cigarettes a day, and he doesn't exercise much because he just walks a dog once a week. However, he has got a good healthy diet because he has a good wife who cooks for him every day, and his wife is a vegetarian, so it influences his vegetarian intake as well. He doesn't sleep well at night, and he thinks that he's gonna suffocate and die from sleeping because he got breathlessness. We have done some objective data from him as well. He doesn't have a good odds that he has got respiratory rate of 26, which is out of the normal range of 12 to 20. He has got high blood pressure, as I mentioned before, which is 153 or 93, which is out of the normal range of lower than 120. He has got a low oxygen saturation level of 87%, which is too low, and we're going to concern about that. He has no pain right now, but he sometimes has pain when he moves himself and while he does some daily activities such as showering. We inspect his skin color, which is paler, and his breathing pattern is not normal, that he has got tachypnea and orthopnea, that he thinks that when he is in this position, this tripod position, he feels better. And we inspected his chest shape as well, that we can see here his chest shape is much larger than the normal person, which is called barrel chest shape. He has got spoken and slow speech as well, and we think that is due to the breathlessness. We palpated his lung shape, which is expanded too much, and we percussed his lung sounds as well, which is a drum-like sound, and we think that is due to the air-filled lungs. We auscultated the lung sound as well, but we can't hear anything because of the air inside the lungs. There are some diagnostic tools for emphysema, including the chest X-ray, ECG, CT scan, complete blood count, oxygen saturation level, and breath holding test. We have got CT scan and X-ray from David. Here is David's CT scan. In comparison with the normal person, we can see there are many dark holes in the middle of the lungs, which means that the air sac of his lung has expanded too much. The X-ray here is much darker than the normal person, and the diaphragm is infected than the normal person. It shows that his lung is air-filtered. Rachel will be doing the pathophysiology part of emphysema.
Hi. So emphysema is a chronic disease that developed over the years. It is part of COPD group. It is the impairment of gas exchange and by narrowing of the airways of the distractions of the alveoli. Emphysema is an incurable airway disease of the lungs. It is classified of the obstructions of the alveoli, its wall, and the elasticity. In anatomical structure of respiration, inventations, and gas exchange, it allows us to breathe the oxygen in and exchange carbon dioxide out. The respiratory tract is divided into two parts, which is your upper respiratory and lower respiratory. In the lower respiratory, we have trachea, bronchiole, and the alveoli, where the gas exchange occurs. When the oxygen travels through the upper respiratory and it will exhale throughout the nose. In the normal lungs, the normal alveoli have rich in blood supply and circulates in the alveoli, as this is where the blood exchange occurs between the oxygens and carbon dioxide. Each alveolus are wrapped up with elastic fibers, as this allows the alveolus to expand when receiving the oxygens and deflate of the exhaling carbon dioxide out. The gas exchange happens in every alveolus and capillaries. Emphysema is the loss of elasticity, both internal of the bronchiole and the alveoli. Also, emphysema is the abnormal permanent enlargement of the airspace with destructions of the alveoli and the alveoli wall. The main reasons with why the alveoli and the elastic fiber gets destructed is because there's a main reason because of the cell that secretes chemical substances, which is called protease. This is an inflammatory response. An increase in protease results in the destruction of elastic fibers and collagen. This will cause an enlargement of the airspace and destructions of the alveoli and the wall. So in general, protease could cause the destructions of the alveoli and the elastic fibers. In original, because the alveoli itself does not enlarge, it's the airspace that gets enlarged. So the enlargement of the airspace will cause serious symptoms. The blood supplies will also be affected due to the damage of the alveoli. The bronchiole of the emphysema will have a thicker wall to compensate and increase the mucus due to the inflammatory response. This contributes to the narrowing of the airways. The narrowing of the airways will cause difficulties in breathing and particularly shortness of breath. These are the symptoms of the emphysema. Dyspnea is usually the most common symptoms of emphysema. This usually causes discomfort of breathing, and also the other symptoms are slow breathing, coughing, wheezing, and weight loss. If the disease gets severe and left untreated, you could respiratory failure and heart failure can be results. There's a diagnostic test of the emphysema, such as signs of barrel chest and muscle wasting. Next, Landis will be talking about the complications.
So there are a few complications of emphysema, including the chest infection, CV problem, which is the cardiovascular problem, and the pneumothorax. Chest infection may occur when the patient got a poor immune system, while our patient David has got emphysema, which means that he has got a compromised immune system, and chest infection may easily occur. Cardiovascular problem may occur when the patient air sacs has expanded too much and they will compress on some capillaries, and when those capillaries are dysfunctioned, the heart has to pump stronger so that the blood supply and the oxygen supply can compensate on the healthy capillaries. Because of the workload of the heart, and severe problem may occur, such as heart failure. Pneumothorax is the collapse of the lungs. While the ASS has expanded too much, they may burst someday and the lungs may collapse someday. We will introduce two medications to David. The first one is salbutamol. It is a drug class of beta-2 agonist. It acts to stimulate beta-2 adrenergic receptor to activate the specific enzyme. And this enzyme forms ATP, which is used to relax the bronchial smooth muscle. The indication include to treat the emphysema, chronic bronchitis, and asthma. And it also prevents exercise-related asthma. The contraindication includes the allergy and pre-existing cardiac problem. Adverse effects include the palpitation, headache, and tachycardia. We have to use this drug on David carefully because he has the high blood pressure. A patient who has got epilepsy, heart disease, and hyperthyroidism, we also need to use this drug carefully. We need to monitor this drug as well, both the effectiveness and the adverse effect of this, and we will see if the chest pain has released and if there is any allergic event. And later we will be talking about the second drug to David.
So N-acetylcysteine is a drug class of mucolysis. The actions of this drug is breakdown of the mucus. The indications of this drug is to reduce the congestions in people with pneumonia and chronic respiratory disease, like emphysema. There's a contraindications of this drug. Patients who have esophageal problem, this drug will not be suitable for those patients. There's also side effects of this drug, say like stomatitis, GI upset, and bronchospasms. We need to be aware of this drug because this is not suitable for acute bronchospasms and peptic ulcers. Also, we need to monitor this drug as well because N-acetylcysteine is pretty much similar to salbutamol. So next, Walaa will be presenting nursing management.
Hello everyone. After all the investigation we have done, we will discuss some nursing intervention. According to Betty 2013, we will monitor the respiratory rate, depth, and effort. If the patient using his accessory muscle to breathe, monitor, and then we will assess and monitor the vital signs, blood pressure, pulse every 2 hours. If the respiratory rate increased, that means the patient is having tachypnea, and that's what happened with our patient David. And signs of any tachycardia, dysrhythmia can reflect hypoxemia, and we have to monitor that every 2 hours so to manage any sign and symptoms. Monitor oxygen saturation every 1 hour at least by using pulse oximetry. According to Casey 2013, if oxygen saturation is less than 90%, that indicates significant oxygenation problem. In our case, David's oxygen level is 89%, so we need to use oxygen therapy for him. 2 liters for at least 15 hours until the level of oxygen is increased. We will monitor client behavior and mental status for onset of restlessness, any confusion and agitation. Any change in the behavior and mental status that can be an early signs for impaired gas exchange, according to HISCOP 2013. Inspect the patient skin color and observe for any signs of cyanosis, especially the tongue and lips color. Cyanosis means resulting from decreased oxygen level in the blood, and this is indication for a serious problem, serious hypoxia that need a medical intervention. We will escalate the breath sound from 2 to 3 times, from 2 to 3 hours. Any presence of faint sound with wheezes, that means emphysema. We will position the patient with head of the bed elevated. Position the patient in a semi-foul position. This position for a good breathing and allow the lung for good expansion. Patient education. According to Bob 2011, we will have to educate the patient and one of his member family as well, and that will be his wife. We will educate the patient to do the deep breathing and coughing exercise every 2 hours at least. We will educate him how to do it. Inhale deeply, hold your breath for several seconds, and then cough 3 times with mouth open. This exercise, David, can increase your sputum clearance and decrease your cough spasm. We will explain the disease process to David and his wife to be aware of the process of the disease, signs and symptoms, and when to seek for help and medical intervention if they need. We will educate the patient how to administer his inhalers and how to use his medication correctly. Encourage David to quit smoking. By stopping smoking, David, you will may slow the progression of COPD. We have potential problem, risk of infection and malnutrition. Risk of infection, we encourage him to take flu vaccine as a kind of protection from getting any cold or flu episode. Prevent the exposure to infectious disease. Reduce to deal with people who have any disease. Because you are very vulnerable and you can easily take any disease, and that will reduce your immune system as well. Malnutrition. Patient with decreased level, oxygenated level have a little energy to use for eating, and he will avoid some meals to save the energy for breathing. According to Australia Lung Foundation, patients with emphysema are malnutrition. Encourage the patient to eat several meals, but small one daily. We will have collaborative care team in that case. As mentioned in Australia Lung Foundation, there are many people will be involved in caring for David. Members for multidisciplinary team will be involved. Kara, his wife, to take care of him. Dietitian will assist his nutritional status and give him adequate diet and fluid intake. Physiotherapy will help him to do the exercise, deep breathing and coughing exercise, and how far he can move without getting any restlessness. A general practitioner, he will refer him to a specialist and gonna write his medication and do the follow-up with him. Respiratory nurse will discuss with him the progress of the disease and all the process of emphysema and COPD, and give him any information he needs. Tobacco treatment specialist or quit hotline to help the patient to stop smoking. Last one, the inclusion of NSQHS. We will have two standards to discuss according to Australia Commission on Safety and Quality in Healthcare 2012. Standard 2, partnering with consumers. How they gonna partner with David and help him. Standard 3, preventing and controlling healthcare associated infection. This is our reference list, first one and the second one. Thank you for listening.